Same thing's going to happen with the kneecap, and you might notice some floating around. You might also, after you palpate it, remember we talked about that apprehension test where you're going side to side? You might notice a more boggy feeling by doing that. With that apprehension test, so again, we're seeing how does the kneecap articulate with relationship to the femur and the tibia. If there's that aberrant motion or that lateral tracking, when you go from side to side, especially when you bring that kneecap outside, the patient might look at you like, don't do that, or they might try to grab you because it hurts them. You're also feeling, do you feel any bone-on-bone type of sensation or any grinding under your fingers? You can also try to pull the kneecap out and try to get underneath of it with your thumb or whatever you're comfortable palpating with. Do you feel any roughness or any soreness under there? Also, we talked about tracking issues. If we were to draw a line, so if you put a dot on the tibial tuberosity and then a dot middle patella, where does it lie? You know, are they lining up? Is one here and then one's all the way over here, or vice versa? That could indicate some tracking issues as well. You can also, if you suspect some sort of swelling also, just tapping down, you know, normally there should be a nice type of feeling. There should be shouldn't feel boggy or floating around. If you feel that, there could be an indication that there's some swelling in there. We talked about, we did apprehension test. What was the other? Valgus varus. So we're going to assess now the lateral and the medial. Well, this one we're going to assess the medial collateral ligament. So we're going to put a force from lateral to medial, and we're going to see, do you see any bowing? Sometimes if the patient has a small leg like this, that you can get your finger in there too, you can assess to see if you feel any gapping in that area. Then you would go the opposite way and check to see, do you see any bowing this way or any bowing that way? Do they have any pain when you do it? And you should always ask, does this hurt when I do this or when I do that? You know, and then if they say yes, but you don't feel any gross abnormalities as far as any distension because of the ligaments, just go in and palpate, because they might just have a little mild, sprain of that ligament. You would then have it drop down at about 30 degrees. Again, because this is just going to gap the joint even more, and you're going to go in and do your varus and then your valgus pressure.
So can you differentiate valgus and varus?
So valgus is usually a lateral to medial force, where varus is a medial to lateral force.
Okay.
It gets confusing. And then I'm going to have you, while I have you in this position, then we had the AP draw test. And remember the AP draw test, what are we assessing with the AP draw test? Yeah, ACL and the PCL. Remember, the ACL is going to be the most common one, but again, and that's where the history comes in play. What was the force of injury? Sometimes the PCL can become damaged, so it's important to assess both of those. Usually with this one, like I said, I like to just, you don't have to sit on the patient's foot, but just enough that you're preventing the foot from moving around. You're going to get into the eyes of the spine there, and you're going to pull towards you. Do you notice any gapping? Because you can feel the femur and the tibia at the same time. Do you feel your fingers coming apart? Do you feel any shifting or any give? And then you're going to push down. Again, do you assess when you pull forward? Is it coming all the way at you? When you go down, do you feel it dipping down? That's abnormal. Then you can do that Lockman's test, where you can either support the upper thigh and just pull up towards you, and do you feel any gapping or any give to the joint? Also assess the patellar tendon with some injuries. Sometimes with a PCL injury, there might be what's called a patellar sulcus, where there's a dip because that patella is or the femur and the tibia have shifted backwards, so it's going to create almost like a crescent in here. That could be an indication of a PCL tear. Remember we talked about the patellar tendonitis. So that's that tendon in here. Remember jumper's knee? So go in and like we did with the Achilles, pinch it. I mean, normally, does that hurt at all?
I have some knee problems, so it's very
Do
tender.
you? It's tender? Normally shouldn't, so if it is, then that could be an indication that there's some inflammation of this tendon, possibly because of like a jumper's knee or a tendonitis type of an issue, but it could be from a tracking issue, because that knee has tracked so much, it's creating more tension on that tendon and how it attaches to that tibial tuberosity. You can also, if you're trying to rule out like a patellar tendonitis, have the patient hold your leg in this position. I'm going to try to push down. Don't let me push your leg down. See how that causes this to raise? It's creating tension on that tendon. Normally that shouldn't hurt either, so if it does, again, it might just confirm a tendonitis type of an issue. Can I have you on your stomach, please?
Mm-hmm.
So then we did, forgot one. So then we're going to have her on her stomach, and remember, we're going to do Apley's with compression. You're going to push down, internally rotate, and then externally rotate. What are we checking with this? Meniscus. When you're doing these tests, always think about what are you trying to do, or in your mind, try to picture. So when we're putting a compressive force, so that's going to put more pressure on the meniscus. Also, if we were to pull the leg up and we twist, remember this is the Apley's with distraction, think about what we're doing. We're putting more tension, more so on the collateral ligaments, and we're checking to see if there's any instability or pain there. Normally, there shouldn't be, but if there is...
So you're pulling up while rotating?
Mm-hmm. And that's why sometimes it's easier to use your leg to do it, because you can use your leg to hold it down, use one hand to pull up and twist, maybe the other hand to palpate the joint line. You might be able to feel some snapping in there. Then for like a hamstring tear, we're going to go in and palpate, the belly of the muscles, any tenderness, any inflammation. Have her, hold this up, don't let me push down. You can then look at the tendons a little bit easier. And also, normally she should have good strength in there. If she doesn't, or it gives out because of pain, it's an indication of it could be a hamstring strain, or it could be a low back, like a pinched nerve. But usually if there's pain in the hamstring area and there was an injury, most likely it's going to be a hamstring type of complaint. Can I have you on your back again, please? Then we talked about, remember, McMurray's? And you're going to put your fingers in the joint line. You're going to start in this position, and you're going to extend and bring it up while you're internally rotating, and then do the same thing externally rotating. And you're going to, do you feel a click? Does she feel a click? Does she feel any pain? That could be an indication of a meniscal tear. Again, sometimes with a meniscal tear, if there is a meniscal tear, and with that McMurray's and with the gentle pull at the end, sometimes you can reduce that meniscus and it'll put it back where it should be again. So sometimes the test also becomes a treatment. I think is that everything we covered? Ovaires. So can you lie on your side with this side up, facing that? So with ovaires, again, it's a good way to palpate that IT band and that TFL to see if there's any contractures, any tenderness. But with that test, you can grab the leg in this position and kind of internally rotate the femur there, bring it up, and let it drop. It should drop and almost hit the other knee. If it stays up in the air and it takes a while to come down, or if it ratchets, it's a good indication that there's a contractions in the IT band.
Can you do the rotation one again, please?
This one?
Yeah. So you said you internally rotate
Yep,
it?
you bring it in like that, just let it drop down.
Okay.
Any questions?